Welcome to this discussion on vaccine uncertainty and hesitancy. As GPs and pharmacists, how do we address the public's questions? Our faculty includes Dr. Jeannie Mansberg.
I'm a GP in Sydney. I work in a local government area of concern, so my patients are under quite a few restrictions at the moment, and I'm also a board member of the Immunisation Coalition.
Professor Lisa Nissen from the Queensland University of Technology.
I'm a pharmacy academic and researcher from the university, but I'm currently seconded to Queensland Health's COVID immunisation task force, working in the rollout here with the department.
Communications expert, Dr. Jessica Kaufman.
I'm a research fellow at the Murdoch Children's Research Institute in the University of Melbourne, and I work in the Vaccine Uptake Group.
And Dr. Sarah Chu.
Hello everyone, I'm Dr. Sarah. I work in Brisbane as a GP and I give a lot of COVID vaccines to my patients and to new people outside of the clinic. Recently Brisbane was in the news with the Delta outbreak and a lot of the schools that were affected were within 5 k's of where I live. So I'm looking forward to sharing that with you.
Our first question concerns how we address complacency and avoidance.
When we have patients who are not coming proactively to us seeking a vaccine, probably the vast majority of them, we're not sure what's going on because they're avoiding the GP like the plague because they think they're going to be hit up for a vaccine that they absolutely do not want to get. So there are a range of them. There are those who believe that there are a whole lot of conspiracies at play, or they're going to have a microchip planted in their arm, they're going to be radioactive and spoons are going to stick to their arms. And there are those who are very fearful about the vaccines and have heard and seen on video a number of devastating consequences that have been attributed, I would say wrongly, incorrectly, to the vaccine. And they feel that COVID-19 is of no concern to them, that it's a condition that happens to old people or sick people in Europe and America, and that it's not coming for them. I think there was a very great missed opportunity while COVID was at bay in Australia, where there was an opportunity to get a lot of us vaccinated, and so that this would never have happened, but we were all told there was no race, and as a result, the vaccine uptake was very slow indeed, and I fear that there are some states where that's still happening, where they feel that there's simply no COVID around. I would urge all of our colleagues in WA and other states that are COVID-free, take the lessons from those of us in Sydney who are facing a very protracted long lockdown, and where I wish we were far further along in the vaccination race than we are right now. And yes, it is a race.
And I think people have become very confused about who is eligible, and therefore lost sight of the fact that everybody needs to get vaccinated. So the complexity of the rollout, I think, has added to the issues in the community about understanding when is their turn. And we've found a lot of people saying, well, I just need to wait till my turn in getting vaccinated, but we're not really communicating that to them very well.
We know that younger people maybe are a little bit more complacent. Certainly, they're not necessarily eligible in all locations for the vaccines yet. But one of the things that I think has been really resonant with younger people is talking about long COVID and some of the other risks from COVID that aren't necessarily, hospitalization and death. So there's a lot of uncertainty around, who's getting really negatively affected by COVID. And I think opportunistically, if you are seeing younger people in your practice, if you can sort of bring that home and mention that, it's not necessarily just about those who are going to ICU and dying, who are actually having negative impacts from COVID, I think that might resonate with some of them a little bit more.
So, has the Delta strain made a difference?
I think the recent Delta outbreak has really shown us that it's not just the elderly or people with medical conditions that are at risk. It's really everybody is potentially at risk. Sydney has shown us that a lot of young people have been hospitalised and admitted to intensive care units. So this is not just a disease of the elderly or those with medical conditions. In Brisbane, where I live, we've recently had Delta outbreaks in the high schools and also in a local primary school. So we've seen that Delta not only infects younger children down to the age of, down to even 1 or 2, but it can actually be a source of transmission to the adults as well.
That's a really good point about Delta being now more obvious to people, affecting younger cohorts. And I think from a program point of view, it's caused a real pivot in thinking, where we were really focusing on more vulnerable populations, our older cohort, and kind of working down through the age groups. Now there's a real feeling that we need to be almost flipping and working back up, including high-risk populations like our teachers, and now really focusing on school programs and how we can possibly not just work through the vulnerable populations like our ATSI cohort and our children with complex medical conditions, but how are we going to get a children's program into schools as soon as possible with that TGA approval for Pfizer and probably Moderna as it comes online in those 12 pluses. And now parents are very interested in getting their kids vaccinated, which is good. But, you know, how do we roll that out across a program that's sort of been coming one way, and now we're going to have to come back the other way? And we've got to be really careful not to lose the people in the middle who've been wanting to get vaccinated but haven't been able to because the program pivoted away from AZ.
And what challenges does vaccine hesitancy present?
Where I work, there is a lot of vaccine hesitancy. A lot of my patients were not born in Australia and English is their second language, and they have very grave concerns. A lot of it started as just simply AstraZeneca hesitancy, and they were saying, I'm waiting for Pfizer. Now that Pfizer is eligible, they are eligible for Pfizer up to 50 years of age. We're seeing just complete hesitancy from this group. What's been really interesting is that the young people have been rushing the gates of the local pharmacies to get the AstraZeneca vaccine. All of them cite the desire to do something for their community. It doesn't seem to be a particularly personally advantageous thing in their head. They're doing it for the greater good of people in Sydney. But I've seen a lot of hesitancy from those aged sort of 40 to 60. And that seems to be the group that are most concerned about the vaccine and least motivated by the good of the community and the good of the state. So I think that's a group that I'm looking to focus on. And for anybody who's watching us and is getting really burnt out by having Groundhog Day discussions with their patients day in, day out, you probably need to take a couple of days where you just don't talk about vaccines anymore and say, you know what, let's do this another day. Because I know, speaking personally, that after speaking to people who just say, I'm not interested, I don't want to talk about it, it can really get you down, despite all the 20-year-olds going, no, I want to take the vaccine, and thinking, wow, you good person, thank you. It can really get you down after speaking to vaccine hesitant people for hour in, hour out.
Look, I think everyone is really strongly influenced by conversations with GPs and pharmacists. So it's an incredibly, it's quite a burden. I'm sure that these conversations happen over and over again, but it's also probably the single biggest driver of uptake is getting that strong recommendation from a GP, from a pharmacist, from someone with that health background. I think when speaking with anyone, we know from some of our research that people really want the discussion to be personalized, and that can be hard, but particularly that sort of 40 to 60 age group that you're mentioning, Ginny, may be more likely to have questions about fertility or about underlying conditions, or medical history. And that kind of thing isn't necessarily being addressed in sort of mass campaign, media information. Those conversations have to be had on sort of a one-on-one basis. And so I think for those people, bringing in that personal risk benefit equation kind of discussions really helpful. And for young people who are going for AstraZeneca, it's the same sort of thing. We know that they need to have informed consent to get that vaccine. And so if you can sit down with them and sort of show them some of the, there's the weighing up risks and benefits handout that the government's made. There's a couple other independent decision aids that are out there that just sort of help put into perspective, the risk of TTS, but also the risks associated with Delta specifically and transmission, and then really highlighting the benefits outside of disease prevention. So, as you said, Jenny, people want to, protect the community. They want to be able to go to the grand final, not be in lockdowns, have travel, come back. So sort of emphasizing that those things, we have to get to this 70%, we have to get to this 80% to do that. I think those are really motivational messages to be sharing with everyone.
We asked if the faculty had any special advice that would be helpful in addressing hesitancy.
It just comes down to eliciting the how, the why. I mean, why should they get the vaccine? And if you have a strong enough why, you can motivate a lot of people to change, or, to generate that change from intrinsically within. So sometimes it might be harnessing, well, what's important to you? For others, it might be protecting their loved ones, their family, people that are not in the eligible age groups, children that are too young, infants, for example. So I think finding a strong enough, why should they do it? Because it might not be a personal risk to them, although that's really changed with the Delta variant. I think finding out, what's important to them, their lifestyle or their loved ones around, you can usually find a reason for them to roll up their sleeve and get vaccinated.
You have to find the thing that moves them. And I think our experience with some of our communities is that it's actually not about the microchip. It's not about, the ingredients of the vaccine or how fast it's been developed. It's actually rooted in very deep cultural background issues around control, lack of feeling of consent. So it's a number of other issues that you've actually got to unpick, that the vaccine's actually this thing that you see, but it's a whole lot of other things. And when you can start to work through those, which take time, it takes lots of sort of conversations. It may take months and months to unpick that, and you've got to be patient. And when we want to roll out a vaccine program right now, sometimes it feels like, that's a forever timeline, but it's worth it in the end if you can unpick it.
That really resonates with sort of what we have seen in communication research around all vaccines, is that it often takes multiple conversations. And sometimes the best thing you can do is just leave that door open, and make sure that you aren't, running up, butting your head against a wall all the time, so that they still trust you. And I think that's exactly the approach we have to take. And part of the hard part of the whole rollout has been we haven't had the vaccines to give to the people who are the uncomplicated, get it in me, I just want to walk through the door and get it. And the more people we can vaccinate like that, the more normalized the whole process is. And so I think we are sort of dealing with some of the hardest to convince people while we still have easy, low-hanging fruit left on the tree. So I'm really hopeful that when we, increase our supply over the next couple of months, some of that will simplify the process a little and free up some of your time to really focus on those people who benefit from your sort of repeated interactions.
Vulnerable groups are an ongoing concern.
So I've been really intrigued by the amazing work done by Nacho and Pat Turner, and that element of community control that I think has had 10 years in the building to get to the point where they could stand it up and create local community control organisations that could help get vaccination into a very vulnerable group that was not necessarily inclined towards vaccination by a group of whiteys in the first place. It hasn't been successful every time, first time, but that community control element has been a real model for how this could be done. And I'm really interested in looking at that model for some of our other vulnerable groups, so that the people who are telling them about the advantages of vaccination don't always look like me. So I'm interested in how we can engage with some of our migrant or refugee communities, have language that is appropriate for them, delivery of vaccines, delivery of information in a culturally appropriate, linguistically appropriate way from community members that they trust. I think that the way that Nacho has worked is just a really good example of a system that we could now take and then pilot into other communities. It's probably too late to stand it up for this particular pandemic, but it's not going to be the last pandemic, and it's not going to be the last health crisis faced by some of our more vulnerable communities. And as we have all found out, all of us are only as safe as our most vulnerable, particularly in a pandemic, and all of us are only as free to live mask-free and go out and enjoy with our friends as our most vulnerable. So this would be a really good investment for all of us to invest in all of our vulnerable communities and see if we can replicate the amazing work done by Nacho.
I was just going to add to that. I think, through the state departments, certainly from my understanding across the others as well, like we've been partnering with the coal communities as well as the First Nations groups to give them added capacity to do those deliveries by providing extra vaccine, by giving them support workforce, and to do that adding from the back end to free up their workforce to do the front end. So if that's about administrative support, mixing the vaccine, they call it potion mixing, so making the potions so that they can do the conversations and the vaccine administration with people at the front end from trusted folk who know them and can see that the health workers getting vaccinated, so they can see that it's okay, so that they can go on and get vaccinated. So we've been able to lever those relationships and help to boost their capacity to do more in their communities. And my understanding is the health services sort of across the nation have been working with those types of groups to do more of that.
Yeah, definitely. In Victoria, we've been working with the Department of Health to run a vaccine champions training program. So we sort of about how to have those conversations about the vaccine. So not even sort of the medical side. And we train all kinds of people. So faith leaders and community leaders and sometimes healthcare workers, and really anyone who needs some strategies, some ways to answer questions that people have about the vaccines, and then have that, they feel that little bit more empowered to go out and answer people's questions. And as you said, Jenny, they're from that community. So what they say is much more trusted. It has much more impact. And I also wanted to draw people's attention to a recent glossary of COVID-19 terms that was put together by Holly Seal at UNSW. And it's translated into heaps of different languages, and it's all different ways of sort of simplifying lay language translations of complex terms that you might want to use if you're trying to explain something like TTS to someone. So it might be a useful resource if you are trying to sort of simplify those languages for people with different levels of health literacy.
It's useful to consider what safety concerns are most usually expressed.
One of the questions that I often get asked is, I don't know whether this is a safe vaccine and whether it's going to give me long-term problems like cancer down the track. So actually, we've been dealing with vaccines for centuries. This is not a new thing, vaccinations. And one thing that we know is that vaccines and their components actually break down in the body and leave the body quite quickly. And we don't tend to see long-term consequences of vaccine. We see short-term consequences of vaccine. And you can get a nasty fever and a sore arm and feel really quite sick, and that's just because the immune system's activating. But we don't see these long-term consequences. In fact, if anything, they wear out. They're out of the body too quickly, and what we need is boosters, quite the opposite. We need to put more in to keep them going. I like what you're saying. I think it's good that you've thought about it, but I can reassure you on that one, that doesn't tend to be a problem with vaccines.
Again, I think Jenny's answered that question really, really well. One of the common questions is, has this been made too quickly? Have they cut corners to bring it onto the market? What does it mean that it's not fully approved, that it's only approved for emergency use? So I break them down and I answer them one question at a time. So in terms of explaining, have they cut corners, I normally take it back a little bit and say, look, how are the vaccines normally developed? And taking it even back a step further to when we had SARS, back in 2005, that, we were ready and we knew that it's not going to be if there's another pandemic, it's going to be when. So some of those seeds were sown before and we were prepared, and there were platforms of different types of technology that were, made in advance and ready to be developed at short notice so that we could respond quickly, not then, wait and then to perform research and then, develop from day one, when we respond to the next pandemic. Breaking it down and explaining the phase 3, when we can recruit very big numbers very quickly, as opposed to some rare diseases when it might take not just days, months, but maybe even sometimes years to get adequate numbers, really helps them to understand, no corners were cut. It's just that we were able to, complete this in a very quick time because of, unfortunately, the number of people that were infected. So in terms of answering that, most people feel very happy actually when they understand that and they realise, no corners were cut. This is a very safe vaccine. And although we don't know long term, what the side effects are, we already know what the long term side effects of the COVID-19 infection can be. And we know that although most cases might be asymptomatic, that's not always the case. And relatively mild cases might lead to long COVID in, as little as, 1 in 3 people. So although it might not end up, landing you in hospital, in the ICU, not necessarily die, there can be very devastating, morbidity consequences, even if you survive COVID. And that's not to say that you'll get long-term protection either, because we know you can be hit with COVID and contract a different strain, again, as we've seen in India.
We've seen in our lifetime an amazing advancement of technology. And so now Tesla has amazing technology in cars, and we have these incredible phones that do all of these amazing things. Guess what? There's technology in health as well. And that has allowed us to go at rapid speed, particularly when a lot of money was thrown at this project. But we are not still... Louis Pasteur with a micropipette in a lab anymore. We've actually gone past that.
Next, we discussed patient questions around the vaccine and its effects on fertility.
I get asked a lot about infertility. So there are a lot of women who have seen on social media different people claim that the COVID vaccines will impair fertility. It's hard to track down where that came from. There is a purported Pfizer leaker, which there always is online, where they have given a secret to 20 million people on YouTube but denied that information to the government, who found out that, in fact, Pfizer vaccines were denied to women of reproductive age in the trials. That is standard protocol. We don't tend to start our trials first in women of reproductive age until we're really quite certain of their safety and efficacy, and then we broaden the trials to include women of reproductive age. That's just a standard protocol with any medication. There are also women who have gone onto Instagram or onto TikTok to say that they had a particular vaccine and then their period came late. Women's periods are all over the show all of the time. Your period coming late is probably just because your period was coming late, and it's not attributable to the vaccine. So at this point, we have reasonable data to say that the vaccine is effective and safe for women who are pregnant and are trying to become pregnant. On the other hand, COVID itself has quite nasty adverse effects for both the pregnant woman and her unborn child, and those last for 6 weeks post the birth of the baby. So we would really urge women of reproductive age to consider getting a vaccine for the health of herself and for her baby.
The concerns around fertility and breastfeeding and pregnancy, I think, are really important, and they're particularly important because they haven't necessarily been addressed in broad communication campaigns to this point, partly because we've been, I guess, trying to work through the eligible groups, but we know that people's concerns don't stop festering just because they haven't been targeted by communications. But the other thing that I think is really going to become an issue soon is women in that age bracket are often already mothers of some children, and women tend to be the main decision makers for vaccination of their children. So if you have women who are hesitant about the COVID vaccine for themselves, they're almost certainly going to be even more hesitant about the COVID vaccine for their children. And a lot of the concerns around fertility also are part of the reason that people have concerns about vaccinating children, particularly young women. And it's all sort of connected. So I think it's really important to be trying to get on top of these concerns. We know they continue to be spread in different communities, and really to have that eye forward to the childhood vaccines, bearing in mind that women are such a key target audience to communicate with and to build confidence with.
The other concern that people have is particularly with the Pfizer vaccine and the Moderna vaccine, is that the DNA is going to stick. And I think because you pointed out earlier that it disappears really quickly. So what's in the vaccine that stimulates your immune system and the vaccine components itself disappear very quickly out of your system. And so I think if you can talk through how it works and what happens, that idea that you're going to have COVID DNA in your system helps to sort of talk people backwards out of it. If I reflect on the conversations I've had to mums who are now, with kids in that 2 to 15 who've got complex medical conditions that want to get them vaccinated but don't want to because they're young women, I think they're the conversations when you talk to them about, what happens to the DNA. They're like, oh, the DNA is going to get into her system and she may not be able to have kids. When you kind of talk backwards on it, it kind of makes sense to them if you can have a logical conversation.
Yeah, absolutely. The same things that you've said, will this change my DNA? And explaining the differences between messenger RNA versus DNA has been really interesting. And then some people will even ask about CRISPR gene editing, and looking at the costs, I said, look, I think it'll be near impossible for them to package that into a $5 vaccine currently, because it would not be possible to recoup any profit from this. So sometimes they just have a bit of a laugh when they sort of see it from a bit of a more humorous side. But again, pregnant mummies, we've had some conversations, and a lot of it is, saying, look, I hear you. It sounds like it's really difficult to be a mother at this time. There's so much uncertainty. All you want to do is do the best to protect yourself, which will also protect your unborn child. A recent conversation, again, reflecting what Ginny said, if you receive the vaccine now, you're eligible because you're pregnant, but in 4 weeks' time when you deliver, you won't be pregnant anymore. But so if you're breastfeeding, you'll still be recommended to have it, but you won't be eligible. And it also means that they might lose out on the antibody protection that will pass through the placenta and only rely on what will come through on the breast milk. So I recognise it's a very, very tough decision. But again, sowing the seeds, giving them lots of time, having a chat, and it might even be with them, chatting from, multiple perspectives with their pharmacists, with their obstetrician, with their midwives. And when they hear the same consistent message over and over again, especially from their antenatal care providers who've heard of lots of other pregnant women receive it with positive experiences, I think they feel a lot more comfortable.
I think it's really powerful that the vaccines are recommended by like IVF providers. So if anyone was concerned about anything that might make it difficult for someone to conceive, surely it would be the doctors involved in in IVF treatments, and they're recommending vaccines. So I think sometimes it has to do with the body that recommends it. Breastfeeding Australia, the College of Midwives, these different organizations. I think if you can point to their recommendations, that can sometimes strengthen the recommendation that you're making.
Many GPs and pharmacists are having to deal with conflicting health advice from some patients.
That can be really difficult for a primary care physician or a pharmacist to counter when the orthopaedic surgeon or the cardiologist or the dermatologist has said that they should not be getting an AstraZeneca vaccine because they've had a previous DVT 12 years ago or that sort of thing, which we are seeing an awful lot of. This can be really difficult for healthcare professionals who have a little bit more understanding of the difference between TTS and a standard VTE to manage, because we don't want to throw our specialist colleagues under a bus or disagree with them too hard. I'd love to just collaborate with my colleagues here about what is the best way to handle that particular conversation when we get even a specialist letter coming into them saying, I don't think this patient should have an AstraZeneca vaccine because their grandmother had a blood clot in the leg after surgery.
The form that Queensland Health has released has been immensely useful. So I'm in a clinic that offers AstraZeneca vaccinations as well as Pfizer vaccinations. So we often see people who will turn up who are not eligible for the Pfizer requesting one when they don't meet the guidelines. When we show the patients the form and there's, the standard contraindications, to AstraZeneca or reasons why they might not have it, they can see very clearly whether they meet the criteria or not. And if it's not clear, we say you need to go back to your referring GP or your specialist. They need to fill in this form. In fact, I am putting my foot down, because if they don't meet the first 7 or 8 criteria, whatever it is now, I don't even accept the other, because if it's other, I just say, look, you're eligible for a Pfizer, but not now. You can wait till there's enough supply. When everyone else can have a Pfizer, that's when you can have it, because currently you're allowed to have the AstraZeneca vaccine. It's on offer, but the Pfizer is reserved for this age group, and I have to follow the rollout rules. We're contracted to roll this out on behalf of the government. And if we don't follow these rules, then it's not fair for everyone else. It's very difficult when some of the vaccination hubs, we hear patients who are over 60 who said, look, they just got a Pfizer because they got booked in at the hospital hub. It makes it very difficult for us to do our jobs when other people don't follow the rules. But I said, look, if that's what they do, then you should book in over there and you should go there and try your luck. I said, look, I follow the rules and this is what we'll do. And when, I've even had a hematologist who said, who's checked splanchnic, increased risk, is at increased risk, has not had this, but is at an increased risk because of this condition. And I say, no. So, he can organise the Pfizer vaccine for his patient if he feels that way, but currently she doesn't meet the criteria either. And if she has a reaction, to the, say she has that outside of the guidelines and she has a reaction, a devastating one to the Pfizer vaccine, where does that leave us in terms of indemnity as well? So it's, we want to do the right thing, not just for the patient in front of us, whether it's by omission, commission, but also we've got a responsibility with this resource scarcity to the rest of the community as well.
Whilst there has been a pickup in the number of first doses, we must communicate the importance of the second dose.
Our clinic closed the books for COVID vaccines to all non-patients because it was just getting out of control. In terms of the second dose, as we upload it to AIR, we also upload into their software a reminder that comes in as an SMS to the patient. But also what we do is at the same time we book them in for the second dose before they even get their first dose. So once the doctor has said, yes, you are eligible, we are going to go ahead and do this, you move to the next room to get the vaccine administered by a nurse. But the first thing we do is book you in for your second dose and then add the SMS reminder.
Yeah, I can add to that. I mean, pharmacy's fairly new into this. So, we started our pharmacy rollout in beginning of June. And those pharmacies were on the eligibility checker and had booking system available, not that different to HotDoc. So it's an online booking system for people to book in. So it works similarly that once they've had their first vaccine, they get a booking for their second vaccine straight after that. Those are uploaded through the software in the pharmacies through MedAdvisor or GuildLink into AIR directly. So those vax records go straight up into AIR. So they will be available if they went to another pharmacy or they went to a GP. We've done probably a third of the vaccines have been second dose, particularly in those regional rural areas where the HHS had been through first dose. So Barcaldine, for example, regional rural area in Queensland, pharmacy's done primarily second dose vaccines there, where the Longreach hospital had done the first dose. So in that case, people were coming in for their second dose to the pharmacy and booking in there. I think the advantage pharmacy has had, and I think go back to that first conversation about being patient and persistent with people, is that pharmacies are offering walk-in opportunities for people. So while they can identify the pharmacy on the eligibility checker or find the pharmacy service, they can walk in and say, I'm interested in getting a COVID vaccine. Could I get it now? So I think that overcomes some of the hesitancy created by having to make a booking.
This is a pandemic. It just means it's all hands on deck, and whatever way it helps our patients to access the vaccines is incredibly important. I think there's so much information out there. A lot of people really don't have a lot of questions that they haven't had answered. And if they do, they are quite proactive at reaching out and touching base with the GP or their healthcare provider to have that answered before they have that shot in their arm. We do the same thing as Dr. Jenny. We book them in for their second appointment straight away when they're having the first. In fact, some of the reception staff have checked even before they book in for their first to make sure they can come in for their second. Because of the set number of vaccine doses that you can extract from a vial, it's very inefficient and potentially wasteful if we don't get the right number booked in. Although we have a cancellation list, I imagine the same as a lot of other clinics, it just creates that extra workload. That reception is already at full capacity. It just creates extra work that we don't really need at the moment.
I guess I would just add that we know from when we're trying to get that last group of people, one of the more successful sort of simple nudge approaches that's worked for other vaccines overseas and in Australia is this idea of sort of pre-booking someone and sending them a text and saying your vaccine is here and we've booked it for you. And that sort of presumptive approach, I guess, of booking overcomes a lot of people who maybe just haven't gotten around to the booking part, or it's not exactly complacency, but it just is that little bit of a nudge, as we were saying, to push them across the line.
So, where from here?
One of the great things that's going to happen is that the Moderna vaccines are going to go straight to pharmacy. So I just think that gives our patients a much greater range of choices. I think that pharmacy can be a less threatening space and just easier to get into, particularly as Lisa was explaining, the walk-in nature of many of the pharmacy clinics. So I just think that's a really excellent development. I was really happy with that decision by the government to go that way. It just means that patients can access mRNA vaccines from state-run hubs, from GPs, from pharmacies. We've just got to make sure we can do whatever we can do to get vaccines into arms.